Hi guys, we are doing a presentation on opioid substance use disorder and treatment from group number 3 by Celine, Audrey, Janelle, Lisa, and Celine. Next slide. Opioids are beneficial as a medication to relieve pain from moderate to severe, and it elevates the body. It can make people feel high when the body relaxes, as some may even use it for reasons that aren't non-medical. The legal use of it is usually prescribed by the doctor. Next slide. Nevertheless, opioids can be very threatening when misused, and it's a drug that is immensely addicting and it can result in overdose or even death. Narcotics, morphine, and Oxycontin are the most common opioids used for prescribed medicinal treatment on patients who are suffering from severe amounts of pain or illness. Even so, opioids can be very threatening and result to overdose and death, as I mentioned from the very beginning, just because it's also a strong pain reliever that can be predominantly used for people who are suffering from any illnesses or pains. Next slide. Besides pain relieving purposes, long-term consumption on opioids comes with high risk of opioids use disorder, or the OUD, and paradoxical or imbalanced effect on their emotions tend to become more restless, agitated, and furious. An individual would go through episodes of desperately ingesting the opioids when the addiction and the drug abuse stages had already settled in their system. Next slide. And with the opioid data analysis and statistics, in the United States, heroin is also a very well-known opioid, but it is illegal and is under no circumstances of being used as a prescribed medicine for patient treatment or anything to cure pains or illnesses. And from 1999 to 2019, approximately 130,000 people just died because of the misuse and overdose of heroin, but about a total of 500,000 deaths, including other kinds of opioids, are prescribed and medicinal, that people have died from it as well. Next slide.
To go deeper a little bit into opioids, opioids are able to bind to our brain's receptors as they disguise and mimic natural pain inhibitors like endorphins and enkephalins. Opioid receptors are GPCR or G protein coupled receptors. Therefore, they have G proteins within their cells where, when it's binded to opioids or neurotransmitters, the G proteins would act on and launch the signal. Opioid receptors are classified into mainly four classes, wherein the GPCR structures are similar but have different drug binding sites. These are the mu, kappa, delta, and NOP or nociceptin opioids. Next slide. There is a continuous flow of signals being released and received from neurons to neurons with the help of neurotransmitters to its receptors. This is how our brain sends signals on how we feel, react, think, and move. When opioids enter the system, certain neurotransmitters are blocked, which can either inhibit or stimulate neurotransmitters. For example, cocaine attaches to receptors regulating dopamine, which causes a feel of euphoria. And another example is nicotine, which attaches to receptors regulating acetylcholine, which affects another neurotransmitter that accelerates neuron activities in the brain. Next slide. Opioid receptors are also found in our nervous system, mainly in the neurons. As the opioids bind with them, a chemical release will happen in the form of pain relief and or pleasure. The mu is usually the first in line receptor for pain regulated opioids like the beta endorphins and enkephalins, as well as the other medications with exogenous opioids like fentanyl, morphine, and heroin. Binding with the mu receptor sends signals to the neuron to the brain, which causes a reaction of pain relief, and a feeling of euphoria, as I said a while ago, as it increases the production of dopamine. Next slide. Opioid receptors are classified as GPCRs or G protein coupled receptors. These convert extracellular signals to intracellular indicators. These G proteins would link to mu, kappa, delta, or the NOP opioids. The mu, kappa, and delta receptors, when linked to G proteins, inhibits AC enzymes as well as the calcium channel while activating the potassium channel, stimulating the phospholipase and activation of the mitogen activated protein kinase. And there are other accessories which are also needed to strengthen and depend on the effects of opioids in the system. RGS proteins are G protein regulators, which can terminate RGS proteins. Arrestins are proteins that block G coupling and facilitate receptor internalization. And kinases initiate desensitization of GPCRs. Next slide.
Another main topic to consider is, how does addiction occur? Addiction is a perpetual cycle of craving drugs without consideration of the repercussions. A person's first use of a drug causes feelings of euphoria, pleasure, and other positive effects. With constant drug use over time, the user becomes dependent and experiences disastrous effects. There is no distinguishable factor to who is more predisposed to develop an addiction to drugs. There are numerous risk factors that can cause a person to have a greater chance of addiction, and numerous protective factors that can lessen a person's risk. These can be environmental or biological factors. Next slide, please. With addiction comes drug tolerance and dependence. Developing a drug tolerance indicates that the user needs higher and or more frequent doses to feel desired effects. Drug dependence is a precursor to addiction and becomes prominent with repeated drug use. Dependence results in neurons relying on the drug for proper physiological function. Teenage drug users are at higher risk to neurological function damage due to their brains still developing. Next slide, please. In terms of anatomical targets, the extended amygdala is heavily affected during drug usage. The extended amygdala controls stress levels for anxiety and irritability, which characterize withdrawal after a high, causing the person to use drugs again. Some other symptoms of withdrawal include muscle and bone pain, sleeping issues, nausea and vomiting, cold flashes, and slow breathing, which can lead to hypoxia. Hypoxia is when too little oxygen is circulated to the brain, which can result in coma, brain damage, and even death. Next slide. Let's take a closer look at the physiological aspect of withdrawal symptoms. Opioids bind to and activate opioid receptors on brain cells, spinal cord, and other organs. The opioids tend to target areas of pain and pleasure, resulting in a user to crave that repeated high. Withdrawal can be discretionarily treated with methadone, buprenorphine, nicotine, naltrexone, and disulfiram. Methadone is known as a synthetic opioid agonist that lessens withdrawal symptoms and slowly acts on opioid receptors in the brain. Naltrexone is an opioid antagonist that blocks activation of opioid receptors and stops the effects. Sulene will go into further detail regarding these medications.
All right, so let's talk about the ways opioid substance use is treated. So medication that's most commonly prescribed by doctors is usually categorized as either an antagonist, like Audrey was saying, or an agonist. And they usually act as competitive inhibitors. So you might have heard the term competitive inhibitor before, but basically it's a substrate that binds to an active site on an enzyme on a receptor. So in our scenario, the substrates that would be competing for that active site would be one of two things. It could be the illicit substance that someone's taking. So it could be heroin, morphine, etc., versus the actual medication that doctors are actually trying to prescribe the patients. So going into what an antagonist means, Audrey also kind of talked about this too. It just means that the substrate binds to the active site, but blocks the receptor. Therefore, the cascading pathways don't occur. Versus an agonist, the receptor binds to the active site, but it activates receptor proteins, second messenger pathways, etc. And so now going back to the medication that medical professionals typically prescribe patients who are looking to curb their opioid substance use, there's actually a multitude of different medications that they can prescribe, but most commonly it's methadone, buprenorphine, or naltrexone. So methadone, going to the graph on the bottom left, or that photo, starting from the left, methadone is a full agonist. So it completely binds that active site, activates the chain of reactions. It primarily acts on the mu receptors in our central nervous system. And then buprenorphine would be considered a partial agonist. So that means it only partially binds to the active site, and therefore the chain of reactions is actually to a lesser degree. So it only generates a limited effect. And then lastly, we have the naltrexone, which is an antagonist. So when it binds to the active site, it actually blocks the receptor. So therefore, there is actually no effect. And it usually binds to the mu receptors as well. And actually going back to buprenorphine, it typically binds to mu, kappa, and delta receptors. So now if we look at the graph on the right, we can also get a better sense of kind of how receptors activate and kind of timing. So if you look at the red line, that's actually heroin. You can see that it binds to opioid receptors really quickly and activates really fast, but it also wears off really fast too, which is why for folks that are taking opioid substances, they typically over time have to take more and more and at more doses. And then if you look at the blue line, methadone, it doesn't activate as quickly, but you can see that its effects are a lot longer. And similarly with buprenorphine, the green line doesn't activate as quickly, but it is a lesser effect than methadone. And naltrexone would be the purple line on the bottom. It completely blocks the receptors overall. And going back to methadone, it's actually one of the medications that was one of the first basically that's out there to help treat folks with opioid substance use. It's pretty effective. It was here since about 1947 and has the highest treatment retention rates. It's typically given as a pink liquid form, as you see on the right, and it can also be given to pregnant women as well to help increase positive neonatal outcomes. Okay, and secondly, we have buprenorphine. So buprenorphine, you may have heard of it before because it can also be given after surgery to manage pain. But studies have been showing that buprenorphine does have lower retention rates because given at very low doses, people tend to basically not adhere to the program. And so therefore medical professionals have to administer at extremely high rates. And so therefore, most people do tend to opt for methadone or naltrexone, which we'll talk about next. And buprenorphine is administered as typically a pill form. And lastly, we have naltrexone. So it is given as an injection, but there is a caveat. And basically, you have to detox from any opioid that you're taking before you can actually take naltrexone, because if you don't, there are very severe side effects. And so with all the drugs or medication that we talked about, it's always good to pair it with behavioral therapy, counseling sessions to ultimately give the best outcome for the patient. And a lot of times people do think, wow, like we're just giving drugs to people that have a drug addiction. We're just trading one addiction for another. But studies have been showing that being able to give these controlled substances, so these controlled medication to patients where it actually either blocks those opioid receptors or it curbs their effects, does end up allowing people to live a more normal life, being able to go to school and go to work as well.
All right, guys, so just to sum up everything that was said in the presentation by my group mates earlier, opioids are a prescribed drug that are used to help patients tolerate pain. However, due to the high that people tend to feel after taking this drug, it is considered highly addictive and can lead to serious problems. Opioids bind to our receptors because they mimic the neurotransmitters such as endorphins and epinephrines. The neurons from the opioids bind with the mu receptor that sends signals to the neurons to the brain, which can cause a reaction of pain relief and a feeling of euphoria as it increases the production of dopamine and therefore causing a high and pleasurable feeling in the body. Next slide. It's important to know about opioids and their effect because, as Audrey mentioned earlier, they are highly addictive and can be very difficult to quit due to the extent of the withdrawal symptoms. Like Audrey mentioned earlier, a lot of people get physical symptoms such as nausea, vomiting, headaches. And I don't think it's like a lot of people really understand the severity that withdrawal from these type of pills can cause. I think this would also tie into what Celine was saying about giving other drugs to help with opioid addiction. I don't, like she was saying towards the end, that a lot of people don't understand why you would give people more drugs to compensate their drug addiction. So I think it's important that everybody kind of gets a general knowledge of the difference between opioids and methadone, naltrexone, and buprenorphine to kind of understand the goal and better ways to help those who are recovering, especially with the crisis we seem to be facing. Next slide, please. So to leave you guys off with some ways that this topic will be or can change throughout the future. Something to leave you with is, how might a baby being born with an opioid addiction affect them throughout their life? And what developmental factors might be affected by this addiction? And one more question for you. How would an opioid addiction affect a patient who is receiving